Welcome to another edition of the Corner Booth Podcast here from the Snowden Deli. I'm Aaron Rand from CJD, along with Bill Brownstein of the Montreal Gazette. And today we are joined by not one, but two doctors, Dr. Laura Sang, Dr. Christina Bianchini, who are both here today. And we're here to talk about something that has gotten, I think, everyone in the healthcare profession upset, concerned. I'm not sure which word you want to pick. You've both written articles commenting about it. It's Bill 106. It's the government's idea, provincially of course, for collective improvements in the healthcare system. So, Laura, I'll start with you. You've been with us before. I know this is something that has bothered you and continues to bother you. What's the biggest issue for you here in this bill?
The biggest issue that, comes up for me is it's only focusing on one part of the problem and in a way that's, not going to give the effects that, you would want. I worry that the way that we're targeting physicians specifically with a lot of sort of undertones that we're not working hard enough, that this is only going to exacerbate the problem by, having more physicians burn out, potentially leave the province, or even leave medicine altogether. I
should mention, you both work in family medicine groups, so you run into the same kinds of problems. And I think one that's a reason you're concerned here is it tends to treat all doctors in the same way. So when the government says collective, you don't all work the same way, and that's part of the problem here. So, Christine, what is it for you?
So, what is Bill 106? I mean, it's essentially a new piece of legislation that's aiming at improving access for, the Quebec population, which is, very much in need of it. But the undertone of this idea of performance indicators, where there's this implication that, as Laura had mentioned, we're not working enough and that we have the capacity to work more, which is really not the case. So for, an example is myself, who took a 3-month maternity leave, went back progressively, working 3 days a week. I'm now at 4 days a week. I'm at 100% capacity of what I can do right now. And the same thing applies for somebody who's on a mental health leave, who still wants to continue working, but is working 3 days a week. Or the other end of things, where somebody who's at that retirement age, but says, I want to keep working, I want to keep contributing to my community. Essentially, it puts us in a position where we're going to impact these performance indicators for all the rest of the physicians and negatively impact their remuneration. So it feels like, the government's telling us you can't work part-time like any other profession could if you need to. And I just think the amount that physicians work is a lot more complex than the hours that we're seeing patients. There's so much hidden work.
This is very highly judgmental. I've never seen this kind of like in this part of the world, dictating to doctors, like judging them on performance, judging them where they can go with the prem and everything else. Like you're almost limiting, and like the disrespect seems like unbelievable. Like on a level, you want doctors on your side, you don't want to turn them against you, and this is what we're seeing in a situation like this. It's shocking.
Yeah, to Bill's point, it is kind of galling, isn't it, that a government would basically say to doctors, sorry, you're not working hard enough.
Yeah. And coming from government people.
Yeah, and we know they're already short doctors. That really is the bigger issue here, not the fact you're not working hard enough, but the fact that there simply aren't enough doctors.
Right.
You also, Laura, wrote about the idea that what perhaps the government doesn't understand is the fact that you have to keep seeing patients because there's nowhere else to send them when they could be doing follow-up somewhere else.
Yeah, exactly. So there's a certain flow that's supposed to happen with patients through the system that, for example, they see me, they're referred for diagnostic testing or imaging, then for specialist follow-up, and then maybe back to me. But if there's delays in every single part of that flow, then they just keep coming back to me, and we're trying to make do and get by while we're waiting for, those necessary steps to happen. And that takes up a lot of my time. I spend a lot of time either, requesting imaging a second or third time if it hasn't been done, calling specialist colleagues to try to figure out what I can do, when someone has, for example, failed first and second line treatment for something. So I'm trying to, wear as many hats as possible while waiting for, my patients to get the care that they need.
But further exacerbating the situation is the fact that you guys are bogged down in paperwork. They want you to see more patients all the time, yet I think you told me you spend about a day a week, Laura, like doing paperwork, and I'm sure you're in the same boat as well. like, how are you possibly able to do all of that plus see more patients? It's like totally insensitive, I would think, on a certain level. And how do you get around that? I mean, how do you have time to see more patients when you're like flooded with everything else?
Yeah, I mean, we don't have more time, and that's where we wish it was more of a collaborative effort that was made towards, working together to come up with these solutions, because instead of telling us work more when we're already at our 100% capacity, I think it would make more sense to say, let's try to find a way to liberate more of your time. So to reduce the administrative burden so that you have more time to see patients. That makes a lot more sense to me.
Right.
And maybe even, diverting some of your work towards like a multidisciplinary team where nurses can see the patients for simple healthcare issues and we can focus on the more complex cases. So it's not, it doesn't seem like a sustainable or even feasible solution for us right now in Quebec, what they're proposing.
And by the way, you end up with, the situation, and we talked about this before as well, if you can't see that patient, what happens? They end up in an emergency room, so what happens? And then the emergency rooms are overcrowded because they can't just have seen a GP. Government doesn't seem to either be aware or care about that either.
But on top of all that are the limitations being imposed on you. Now, if you have to stay in the public field for 5 years and you're limited to where you can go with Prem and all the rest, it's just like everywhere you look, there's like handcuffs being put on you on a certain level. And like you have mentioned, Laura, that it's a lot of people are burnt out. A lot of people want to go elsewhere in the province. A lot of people, in the country, a lot of people are even thinking about quitting medicine altogether rather than dealing with all these limitations being imposed.
Yeah, and I think that what kind of example is this setting for people that want to go to medical school, that are future doctors, the people that are going to be taking care of us? If you don't show that you value primary care, how is that going to incentivize people to go into it? And how is it going to maintain the health of doctors currently practicing to be able to have a long career and do the follow-up that we want to do?
The Corner Booth podcast is brought to you in part by the Snowden Delicatessen, where we are. 75 years in business, the home of Montreal's greatest smoked meat, plus Carnotzel, potato latkes, and the famous Snowden Deli party sandwiches. That's the Snowden Delicatessen. I wonder, too, part of this idea, you just brought up being collaborative and the government to having no clue what collaborative seems to mean here. I know this applies in the hospital system as well. We keep hearing from people at the top, you don't know what's going on the floor. Why don't you talk to the people who are on the front line every day? As far as a doctor goes, you have a union, but does the government say, what can we do, or let's talk about this, and how can we make things better for you? Has that discussion ever even happened, or is this all just top-down decision-making?
I feel like it depends. Sometimes they'll talk with the FMOQ, the Federation for generalists or specialists, and then it'll kind of trickle down and it'll have meetings. But a lot of the time lately, we've been finding out about a lot of these proposed bills and decisions at the same time as the general public through widespread media. So not only are we not being consulted, we're not even the first to know. We're finding out at the same time as everyone else. And it's hard for us to plan and react, because whenever something like this happens, my clinic at least gets a lot of phone calls with patients who are worried, are they still going to have access, what's going to happen? So that creates another burden, another administrative challenge that I have to manage on top of the day-to-day.
I'm wondering for you, so Christina, with respect to what the government needs to know here, what's actually happening on the ground. You're an NDG, you're in the middle of the city. What do you hear from your patients, and what could change to make your situation better? When I say better, I mean for patients, which ends up being better for you.
Yeah, so like I had previously mentioned, I think by working on reducing our administrative tasks and reinforcing the multidisciplinary team that we have in place at family medicine group clinics, like my clinic, where we have social workers, we have a big group of nurses, we have psychologists. So essentially, I think reinforcing the team so that we can delegate some of our work to them so it can be diverted will free up time for us to see more patients. And ultimately, I think that will be a solution to the access to care problem, as opposed to at this moment pushing us to see a higher patient volume. we're worried about that impacting the quality of care. And we're also worried about that really impacting access as well, because, for example, myself, I have an 800 patient practice. I also do a required activity, like government required activity, where I do hospital 1 week out of every 5 to 6 weeks. I do a full ward week. And I'm already, doing as much as I can. But if I were to have another 1,000 patients rostered under me, the wait time to see me is about 3 to 4 weeks. That'll grow to 3 to 4 months. So now everyone that already has access, it's just going to be more difficult. So nothing is kind of lining up for us with this solution.
Laura, you work you're based in St. Jerome, and I should mention that it's not because of Prem. You opted to go to the Southern Laurentians, to do your practice. And I'm guessing the situation there, in terms of, I don't know what your patient load is, numbers-wise, but I can only imagine that how difficult it might be in the city. It's probably equally straining where you are too, because the resources are that much more limited. I think you mentioned that, certain medical facilities aren't even available to a lot of your patients out there. So how is it different, from the city to the country in terms of...
So when I sort of compare what it's been like having done my training in Montreal and then working in the Laurentians, everything is that much more spaced out. I feel like because I'm just further from my hospital base, I don't have the same kind of relationship with the specialists. When I was in Montreal, I knew most of the different specialties affiliated with my training hospital on a first name basis. I knew where and how to reach them. I could call them if I had questions, if I was concerned about someone. Whereas here, because there's that disconnect, I'm slowly getting to know the specialists, but it's really just through consults that I've sent and gotten back. I'm starting to recognize the names and build a rapport that way, but that takes much longer. I don't have the same access to them. I can't call them in the same way. So I tend to have to rely on, calling, the people who work at locating are starting to get to know me quite well with the frequency that I call, just trying to get answers, trying to, get information on how to treat something that is beyond the scope of my practice, but there is a need for it, so I'm doing everything I can to, make that happen.
You were mentioning dermatology, for example, ophthalmology. That's not readily available where you are.
No, so for emergency access, it's happened on numerous occasions that I wasn't able to get the patient in, and I was told I either have to send them to the ER and that they're going to transfer them to a hospital that does have that, or they have to go private. Or sometimes I'll just simply get a message back from our referral service being like, we're sorry, we don't have anyone to see this person. They'll stay on the wait list as soon as someone becomes available. But there's nothing we can do for you. And
can I ask a question with respect to something that came up? And I remember when I brought this up on the radio, a lot of people were just baffled. This color coding that the government has decided is a really clever way or smart way to, I don't know, do what, but maybe level the field somehow. How would it work, and what's the issue here? Why is it a kind of a, I don't know, for lack of a better word, a crazy way to go ahead and try to get more access for people?
So I think ultimately it's an oversimplification. That's the problem with this idea of color coding. So it's that, patients, based on what their healthcare conditions are, will receive a certain color, green for healthy, let's call it, just as an example. And that's really, there's an implication that obviously, depending on what the medical conditions are, they have much higher health needs, will require longer visits. And that's not the case. So there's a lot of patients that are coming in, for example, into the walk-in clinic who've never seen a doctor, who are coming in with multiple symptoms, and it takes me many, many visits to work them up, to diagnose them, to treat them thereafter. Whereas the patients that have active cancers that would be considered higher priority are followed by specialists, see them every 3 to 6 months. And so it's actually, in that case, it's those patients without diagnosed medical conditions that are needing more time with us. And then also, comes the point of refugees and whatnot, all of these patients that are coming in that don't necessarily have these diagnosed conditions, but that do require a lot of our attention. I think it's very much an oversimplification of what the healthcare needs are.
Yeah. Your reaction to it, I'm curious. You feel pretty much the same way?
Very much so. And I feel what's also important is, people are not static. We're complex, dynamic beings. And, we move through these color systems, so to speak, quite often. All it takes is a car accident or something to happen in your life to go from one thing to another to move up the color coding system, and vice versa. Maybe an active cancer patient will go into remission and they'll be stable for many, many years. So it really depends on, the emergency of the presenting condition that can change from day to day. So I don't think that, gatekeeping access based on this, what feels like an arbitrary color coding system to me, is the solution. I really think that there are many other ways that, we can try to work.
So, I mean, basically the government is deciding who merits care and who doesn't. It's their, not doctors deciding, but it's government.
Yeah, at least in what order anyway, right?
Yeah, they want to know, which again is bizarre. Who are they to know? If someone is meriting regular visits, or someone's a hypochondriac, or someone is this, or someone is that, but they seem to be deciding that this is the deciding factor in terms of who you should be seeing, who should be regular, who should be irregular, and all the rest. But on top of that, the whole compensation aspect for doctors, I would think, could create friction among doctors, because you're not working as hard as I am, therefore with the whole with throwing in the compensation issue on top of all that, I find it very divisive.
So when we talk about compensation, I think the bigger issue at hand is the hidden workload that physicians have. So I think when they're talking about working, they're really referring to hours in clinic where you're physically seeing patients, but that doesn't take into account going through all the lab results, calling back people who are sitting at home worried, waiting for the results of a scan to find out if they have a serious condition, filling out all the forms that people need to get payment from their insurance companies or from CNSST to be able to get the treatments that they need. All of the other administrative tasks in terms of managing our schedule and our walk-in spots, and messages from allied healthcare professionals like nurses who are co-following our patients who need our input for managing things. There is such a huge amount of work that we do that takes place outside of the clinic, often, at home. You sneak away from dinner for a few minutes to go check and make sure that, somebody's potassium is okay. There's all of these things that they don't know are happening that don't seem to be reflected in everything that's being proposed. And I think that's where this sentiment of not being valued and not feeling respected, I think a lot of that comes from that too. And that's an important thing to take into account, that the work of physicians is not just what we do in front of the patient.
Can I? You're both relatively young. You haven't been in practice that long, and you both ended up being in medical school together, right? You went to school at McGill. Could you have imagined that you'd be sort of facing these sorts of barriers when you first graduated and said, "Hey, I'm going to become a family doctor"? I mean, and if you had, would you be doing this now?
It's a tough question. I had a lot of concerns even when applying to medical school, because I saw where things were going. I anticipated having to, manage the sort of distress that comes with seeing people going through immense suffering, going through a variety of conditions with hours. But what I didn't anticipate becoming a family doctor was all of the challenging politics, all the administrative hurdles, all of the barriers of the system, and watching people suffer simply because of the barriers that are being imposed. That was something I wasn't ready for. Would I still become a family doctor? 110%, because I love what I do. I feel like this was my calling, and I love the unique care that I get to give patients. But if I had known that this is how it was going to be in Quebec, would have I gone elsewhere? It's hard to say.
You also mentioned about colleagues who are looking at some of this and thinking, why am I sticking around here? I could go somewhere else. Life would be a lot easier, perhaps a lot better somewhere else. You're a young mom at the same time, right? Raising a young child. With this workload, is this something where you really want to stay doing here? Or do you look perhaps and say, maybe I could have a better life somewhere else doing what I do?
So my biggest concern is, for myself, speaking of myself, yes, it's concerning, but I I have such roots here. It would be really difficult to leave Quebec. And I do believe in primary care here. So I invested in my family medicine group clinic. So I'm co-owning. And I did so because I so strongly believe in primary care. And I think that there is a lot of potential. I'm just so concerned about new graduates that are coming out of residency and how they're seeing this situation, because I'm worried about my ability to keep recruiting at my clinic, and then I'm worried about what you had mentioned happening in the minds of everyone else. And if we lose a significant amount of doctors, the chances that we can keep our clinic doors open are not that high.
There's also the issue, by the way, we don't talk about that as much, of people who have been doing this for a long time who are perhaps on the verge of retiring and are looking at this and thinking, well, this is how it's going to stay. I might as well get out now and not wait any longer. And those doctors have to be replaced, which again, to your point, is something of concern, because maybe we're not going to see as many people want to get involved in medicine here based on government regulations.
Well, this is something I've already experienced personally, in that, my GNF clinic was part of a group of 3 other clinics, and with them being unable to replace people who retired, one of our sister clinics actually shut down.
Okay.
And we've absorbed some of those doctors, but apart from myself and 1 or 2 other people, the vast majority of the people at my clinic are over the age of 60. And, apart from me, there hasn't been anyone new who's been recruited over the last 4 years. So every year it's the same sort of scare of, are we going to lose nurses? Are we going to lose more people? And what is that critical number, in which case our clinic will have to close its doors as well? And that would be a huge loss to the community.
Do you ever compare notes with physicians from outside the province and compared to here? What kind of feedback do you get on that, and what kind of talk does that bring up?
I have a few colleagues that work in Alberta, that work in Ontario. I think that, the healthcare system across Canada is struggling to various degrees, but they don't face the same challenges that we face here.
In terms of being told where they can go, how, if they can opt out of the private public system, go private, that sort of thing?
I feel like they have more control over their practice. A lot of them, my colleagues have gone into sort of more subspecialized things like obstetrics and gynecology. And I feel like they've expressed, that it's easier to get the lifestyle that they're looking for. They still face, barriers for their patients accessing care and, being overworked, but just sort of that control that they have over the hours that they work, the type of practice that they have, I feel is a higher satisfaction in other provinces compared to here.
And you?
Well, I think what speaks to it quite a bit is when you go on, social media platforms where we're a large group of physicians in Canada, there's this message now of, we're really thinking about you in Quebec.
Really?
Yeah, really they're feeling for us, because they're looking at what's happening, and it's a very different approach from what's been happening in other provinces. And I think that, in general, other provinces have recently been investing in primary care, and they've done a very good job at doing so. And it's been really helping the access to care issues in other provinces.
You would think that when a government here is kind of messing with you in terms of compensation, in terms of where you can go travel, where you can go practice and all the rest, that they would at least value you on another level and say, look, I know it's tough, but we do appreciate you. But I don't get that sense. I get the sense that it's almost like there's an acrimonious relationship there, like you're the bad guys on a certain level. And I don't understand that. I mean, before, a lot of people felt nurses and teachers were undervalued, but now you're getting more of a sense that the government is really undervaluing physicians.
Yeah, and I do feel, when we see patients in clinic and we see them for work burnout reasons, the biggest reason why people go on work burnout is because they're overwhelmed and they can't meet the demands of their boss. And we feel like, I'm worried that that's what's ahead for us, because we can't meet those demands, those performance indicators. And we're already coming out of a time like the COVID pandemic where we're already, there's a lot of systemic fatigue in the system. So I'm just concerned about burnout and, retention of the doctors that we do have.
By the way, I should mention, we're talking family medicine here. The same sort of problems exist for medical specialists. They're having an issue with the government. We know the situation with nurses and the government. I wondered if once Christian Dubé announced that we were forming Santé Quebec to kind of, this big umbrella organization to take care of everything. Were you optimistic then that that would make a change? Because it doesn't seem to have done very much.
I personally am against centralizing things because I feel like the regions, they know their communities, they know their needs, they know the people that work there, and they're pretty good at managing and delegating things in an appropriate way. But as soon as you centralize, you lose that connection with everyone involved on the front lines, both doctors, allied healthcare professionals, and patients alike. So when you're that far removed, you're making decisions that may look good on paper, but don't actually translate into the care that, the Quebecers need right now.
Yeah, which goes back to this whole idea of collaboration, right? If they do not collaborate with people on the front line, you end up with policy that at the end of the day just simply doesn't make a whole lot of sense, not for actual day-to-day practicing physicians. I would ask you then, we're going to have to wrap up, but give you a chance, if you had to deliver a message to the government, to the health minister, with respect to this bill, to Bill 106, what would it be?
I mean,
In language you can use.
it would be, I appreciate, the concern for the healthcare system, but, even our federation has said that this is not in our best interest. Please consult us, work with us. We're open, we're willing. There's so many of us that want to give our input to make changes that make sense. And I think that there are a lot of things that can be done that don't cost any money that would help, like restructuring AMPs and PREMs, allowing more flexibility. Something as simple as that could help with doctor retention, reduce burnout, but we need all the support that we can to be able to do our job.
I was going to say, is that a me too for you, I guess? I mean, pretty much.
I would reframe that to say that I do agree, but to say that, we absolutely agree that the healthcare system needs reform. Coming again from a time like the pandemic, we, as a group of professionals, we want what's best for our patients. So we want to work together with the government to come up with a good solution to our current healthcare problem, to give Quebecers the good healthcare system they deserve.
I mean, your commitment, both of you, is admirable. I mean, you really have to have a love for what you're doing to do this, because like if you were in any other part of the economy, you'd say, like, I'm out of here. But here, obviously, your love for medicine, transcends everything else. And you guys are young and you're experiencing this now. I mean, you worry that 20, 30 years from now, what this will do to you guys, burn you out or whatever, if you keep having to fight these fights constantly.
Yeah, and I had an interesting discussion with a colleague from another country, and they were telling me that, with the stress of their healthcare system, part of the reason they left was, the high rates of burnout, and they were saying that a lot of doctors in that country died within 2 years of retirement. Wow. And I don't want that to be our reality.
Ladies, we have to wrap it up. I want to thank you both for being here. Dr. Christina Bianchini, Dr. Laura Sank, thank you so much. We'll catch you soon on the next episode of the Corner Booth Podcast. Thanks.